Welcome to the Heart of Prevention, helping clinicians stay up to date on preventive cardiology. This show features leading experts discussing real-world strategies to prevent heart disease, from lifestyle changes like diet and exercise to medical treatments, including new therapies. Whether you're a medical student, resident, or practicing clinician, this podcast challenges, informs, and enhances your approach to cardiovascular disease prevention. The Heart of Prevention, keeping hearts healthy one episode at a time. I'm Dr. Michael Shapiro, President of the American Society for Preventive Cardiology, and now here's your host, Dr. Keerthana Pakanati.
Dr. Khan, Dr. Ndumele, welcome to the Heart of Prevention. Thanks for having us.
It's great to be here.
So today's episode, we're all going to be talking about Beyond the Score, rethinking what we know about cardiovascular risk assessment. But before we dive into some really interesting discussion, I'd like to tell you guys a little bit more about our esteemed guests for today's episode. Dr. Sadiya Khan is the Magistrat Professor of Cardiovascular Epidemiology, Associate Professor of Medicine and Preventive Medicine, Director for the Center for Population Science and Aging at Northwestern University Feinberg School of Medicine. Dr. Chiadi Ndumele is the Director of Obesity and Cardiometabolic Research, Director of the Heart Failure Prevention Program, and Associate Professor of Medicine and Epidemiology in the Division of Cardiology at Johns Hopkins University. Phew, okay, so right at the beginning, I always like to ask our guests to tell us a little bit about their personal journeys. I find it's really interesting and we can kind of learn a little bit more about y'all. So I'd love if you could tell us how you arrived at your careers today and how you really found your interests in cardiology and specifically in understanding risk assessment. And we can start with Dr. Khan.
Thanks for the question. It's really interesting to think back to being a medical student. And I remember very vividly a patient I saw around the holidays who was admitted with heart failure. And it was probably her 10th admission that year, was repeatedly in the hospital. And I remember thinking, we seem to keep tuning her up and she keeps coming back. Is there something we can do for prevention? Fast forward a couple of years and I was in fellowship and I had the opportunity to meet Don Lloyd-Jones and talk about how we think about prevention of cardiovascular disease and started to ask, why don't we think about prevention of heart failure the same way? And that has all come together now with training in preventive cardiology, epidemiology, to think about cardiovascular disease risk assessment holistically in the work that I do as a physician scientist on the spectrum of cardiovascular risk assessment and prevention of heart failure.
Thank you. Dr. Ndumele?
Yeah, I'll go back just a touch further to high school. So I got
It's a lot longer ago, too.
It's a little bit longer, just a little bit longer. Yeah, you don't have to say a lot, a little bit. I got dragged by my mom to a community health program that was doing local screenings in our community, and it was a diverse population. And I was initially dragged in, but by the end, I was really hooked. We did a lot of health screenings. We were discovering a lot of unaddressed risk. And there was a lot of receptiveness to people learning about their health status and having motivation to understand ways they could kind of improve their health. And the idea that we could make that difference really got me, even before I started kind of more formal training. And, by the time I got into medical school, it was clear that cardiology was a special place for me. And then cardiovascular prevention just really harkened back to those initial roots of thinking about communities and understanding that there were a lot of this cardiovascular disease that we're seeing had predictable origins that we're often not addressing, and particularly communities like the one that I started doing work in were some that were not being addressed by a lot of our traditional preventive approaches. So a real desire to make sure that we were providing care and preventive care for people across the spectrum from all backgrounds, and it kind of led to being able to hang out with you all here today. So and I think excited for where this journey has taken us to thinking about how we can prevent some of these bad things from happening.
I love that. And I love that both of you really shared a very personal patient encounter. And I think what I've learned hosting the podcast is a lot of people really start their journey and really keep their focus on patients because everything that we do leads back to the community that we serve. So I really appreciate that. So over the last decade, we've relied pretty heavily on the pooled cohort equations. What limitations really motivated the development of new models like Prevent?
Yeah. So, what happens is that the concept of updating to prevent, I think, really started with a focus on the broader construct of cardiovascular, kidney, metabolic health. So we recognized over the last couple of decades, 3 decades, there's really been this emergence of more and more challenges related to obesity and diabetes and chronic kidney disease that are overlaid on the chronic challenges we know, like high blood pressure and smoking and hypercholesterolemia, and just making things a bit more complex. We also knew that the outcomes were extending beyond just atherosclerotic cardiovascular disease to also be heart failure as a major outcome that's a challenge in this population, which Dr. Khan has lots of expertise in thinking about and predicting. And then there was also a recognition that we needed to be looking at risk a little earlier and thinking about some of the preventive therapies that were emerging beyond just statin therapies. So it just made sense as we were kind of looking at this to start thinking, okay, is the risk calculator that we currently have, which had done wonders for us in a lot of different ways, but was it really going to meet the needs of this population with cardiovascular kidney metabolic syndrome? So I think that really led us to start thinking about what can we do to update things in a way that meets the needs for this population. And Dr. Khan really had already been doing some really remarkable work in thinking about the prediction of heart failure and was really a natural partner to lead things forward for thinking more globally about cardiovascular risk in this population. But Dr. Khan?
Yeah, I think the premise, and you set up really where we were when we started thinking about what are the things that we need to address, specifically cardiovascular, kidney metabolic risk, expanding to heart failure. And the other thing that we talked a lot about in the early days was how much of that risk is accumulating beginning earlier in the life course. And so, really thinking about the early young adult period between 30 and 39 that wasn't currently captured. And especially focusing on the fact that 10-year risk is not really the goal when you're in your 30s, right? It's really the longer term. And so expanding to that 30-year time horizon as well. I think all of these things really set us up to say, what are the important predictors that we need to have in the model? What are the important outcomes? What is the time horizon that we need? And then what are the data sets that are going to allow us to actually do this well in an inclusive way so that we can have a generalizable model that really can serve the communities that we were talking about and be able to allow us to do an accurate and precise job at predicting someone's risk for heart disease so that we can ultimately modify it, right? Prediction isn't the goal, it's the starting point.
Yeah, I love the point you made about for 30-year-olds. Now that I've crossed over to the 30 side, I think the focus is not so much on
Okay, some of us
10-year
crossed it
risk.
a long time ago.
Yeah.
A couple years here and there.
Hopefully nobody makes jokes about what your high school time was. That's okay. We'll see.
Not yet, eventually. But I think I really appreciate your comment about when you're 30, you're not looking at just 10 years, you're looking at beyond that. And I remember you speaking to that even at the ASPC Congress, and that really resonated with me because a lot of my friends and I have had these conversations that aren't even in medicine, but really just people that want to take control of their health and do feel like they kind of are in this limbo period. And I think the point that y'all made about it just made sense to go in this direction, focusing on something that's generalizable to a large population, but also a variety of populations. I really agree with what you guys said, and that resonated with me.
I'll say is that I think it's interesting. Different things are motivating to different people. But obviously, there's a lot of consideration for what's in front of you immediately. The short term risk estimates can have a lot of important implications for how aggressive you're going to be today. But then it really is the case that for a lot of, as you said, younger folks, they're going to want to understand, okay, what is this going to mean for like how happy and healthy and productive I can be later in life? And so I think those long-term risk estimates can really make a difference, but it's not one size fits all. I think having more information is generally going to be better than having less information. And I think that that's one of the nice advances from Prevent here is giving more information on the short and long-term horizon for various outcomes.
And then we can personalize it even more. And so, Chiadi, I think that's really a great point about having more information because one of the things that we wanted to do was have the opportunity to add these optional predictors where we have a base model and that's what we think the predictors that are important and are part of routine screening, so can be easily implemented and scaled for primary care. But in those patients that have kidney disease, their UACR is being measured. In those patients with diabetes, where A1C is being monitored, for patients where we have zip code information and can use that for their social context, we can add those on. And so having this setup also allowed flexibility and was a really important part of personalizing that risk estimate too.
And I'll just say one last quick thing is that I just want to also acknowledge, one of my mentors, Joe Koresh, who was a really helpful partner with Sadia and the rest of the team on using these large clinical databases and cohorts to really help us put this all together in a not long period of time, but to really, give us the opportunity to look at not just the short term, but also the long term and various outcomes. So all really important for the population we're trying to serve.
And what a treat for me to be hearing from people that were involved. I mean, that wrote this, recommendation. I think when we're in medical school and we're learning about things, everything seems so remote in the distance and all the advances. And I think it really speaks to the fact that prevention as a field is really changing constantly. And there's a lot of advancements happening right now. And so definitely excited to be able to chat with you all. Dr. Ndumele, you've studied obesity, inflammation, cardiometabolic health. How well do you feel our current risk tools really capture those upstream pathways of risk? We've touched upon it with prevent, but just I'd love to hear
Yeah.
your thoughts.
No, I think it's a really good question. So when we think about obesity, we're certainly now thinking about risk, I would say, in a couple of different ways. One is that it certainly has its impact on so much multi-system metabolic dysregulation. So it has an impact on what we're seeing with hypertension and with diabetes and with dyslipidemias, resultantly and sometimes directly with chronic kidney disease and albuminuric kidney disease. So I think we're doing a better and better job of capturing that because now our risk models are including more of those components within the model. I think that's really important. I also think that obesity has a lot of direct effects in the cardiovascular system that are independent of those metabolic risk factors. And that's particularly true for the outcome of heart failure. So you'll see that in the prevent heart failure assessment, BMI is a really powerful predictor in there and kind of really drives a lot of risk from that standpoint. And I think including that there is really helpful. We don't have, inflammatory pieces and some of these non-traditional pathways are also really important for the individual. They're not include we don't have, I think, some of the most reliable things that can change risk discrimination yet to include in the risk models. But I think they're still very important. And the way that we contextualize those above and beyond obesity and the downstream metabolic risk factors is to also think about those as risk enhancers that can kind of help further refine how we think about risk for the individual patient. So it doesn't necessarily say that we need to be getting a panel of inflammatory markers in everybody, but having an understanding of that will help us better understand that, hey, there's a little bit more going on here and we may want to be a little bit more aggressive about therapy. But I do think in this current era, we're starting to bring in more of these obesity and cardiometabolic considerations and both the direct and indirect pathways that are leading to cardiovascular disease.
Yeah, I think it's really interesting to see how we've changed our perspective and approach to considering obesity as a risk factor. And some of that, I think, is really driven by the fact that we now have tools to modify that risk. And the idea that cardioprotective therapies can modify risk and improve outcomes for patients with obesity, for patients with diabetes, for patients with CKD through overlapping mechanisms and understanding the biology that drives that common co-occurrence as well as the impact on outcomes, I think is really helpful. And so it's not just an exercise, again, in trying to understand the biology, but using that then to really reduce risk for the long term.
Yeah, the cardiology community, I was having this conversation. Actually, I just came from Obesity Week and I was having this conversation there with some folks. We're very action oriented. So, at the end of the day, describing is certainly important, but we also like to do something about it. So, whether it's people with existing disease or whether it's people who are at risk for disease, the question is, can we modify? And when we can modify, then you see the community get more and more activated around certain issues. And I think we're going to see that there's a lot of anticipation for lipoprotein A, for example. And I think, if those trials come back positive, you'll see a big influx of interest around how we kind of consider that and screen for that and think about that and treat that. I think at the end of the day, Sadia is completely right. Our community has been activated by the fact now that we have a lot more tools for addressing adiposity and its downstream consequences.
And I think we see a lot of that for chronic kidney disease too. It
Yes,
has
agreed.
been a long time coming to have therapies that reduce cardiovascular disease in patients with chronic kidney disease. And so it's really exciting to say that we have opportunities to change that natural history with these therapies. The other piece that you mentioned that I think is just really helpful as we think about this is we love action, but one of the things that I think is really useful in when we start to think about risk and risk reduction is really that shared decision making aspect of it. And so personalizing those conversations. I think we love action for the right patient at the right time for the right reasons, and being able to now have the tools both to be able to quantify risk and have a framework for how to think about whether or not the benefit for that person and how much benefit there would be, and then what the therapies are and what the various potential options are. And so thinking of it more comprehensively and holistically as well. And the cardiovascular kidney metabolic syndrome framework really allows for that and starts the conversation there rather than feeling like you're trying to cover too many things all at once.
Yeah. Yeah. And I would also just say, unfortunately, the reality is that things are just a little bit more complicated than they used to be. So it's not just, hey, there's just high cholesterol, just treat that. We just have high blood pressure, let's get that down and we should be all set. Now, with this more complex understanding of risk, there's also fortunately, a more complex array of tools that often have multi-system effects. So we need to think in a bit more of a holistic, as Sadi just said, way. So if you have that patient in front of you that has diabetes and CKD and other pieces, then, well, there's going to be some additional options we're going to be thinking about that could have multi-system benefits, or MASLD, in addition to obesity and pre-heart failure. So I think that this is just an era where we need to think more holistically, more multi-system. But the good thing is we now have more and more tools with both risk assessment and advanced therapeutics to be able to achieve that. So yeah, I think it's an exciting time for prevention.
Yeah, absolutely. I really appreciate the comments about personalization for the patient because I find that when you're having those conversations with patients, to be able to really show them all the components that go into their overall cardiovascular health can really help them to be motivated to really make those changes rather than just saying, hey, you have this one thing that we can't change. I think the comment about when we see modifiable things, we really become activated and want to change them immediately. And I think that personalization in combination with, the idea of encouraging them to make changes is really powerful.
Agreed.
So, Dr. Khan, your work has highlighted a lot about the underestimation of overall lifetime risk, and especially in younger adults. Have you found that in the clinical setting, like using these prevention strategies, more young adults are kind of changing their opinion about their cardiovascular health and understanding earlier on?
I think it is a really hard conversation to start when someone is young and healthy, right? They're not thinking about heart disease. It's not necessarily something that is going to be an issue in the short term for them. And there are a million other things that they may have on their mind. The nice thing about being a preventive cardiologist is that most patients come to clinic very focused on that question. And so it's always a helpful starting point to say, the reason we're here is to talk about your long term risk for cardiovascular disease, where your cardiovascular health currently is, and what are opportunities to improve it if needed. And so I generally like to think about it from that perspective of saying, if we know where your risk is today for both 10-year and 30-year, if we know what your health factors are using tools like the Life's Essential 8, then we can say, where are there opportunities for movement? And this is where that personalization piece comes in again, because I think some people are really motivated to change their dietary patterns, but physical activity and getting that into the schedule is just a lot tougher. And so it's helpful to say, let's take this one step at a time and identify this key area. Tobacco cessation is another key area where I think, especially for young adults, we're seeing a lot more different substances with vaping, e-cigarettes, and the legalization of marijuana, that thinking about what are the opportunities for reduction or cessation of substance use as it impacts cardiovascular health for young adults can be really helpful too.
So I very much agree, and I think it's fascinating because everybody responds to information in different ways. So I certainly have patients in my clinical practice who younger patients who, when I give them the full picture of what's going on, and more importantly, also help them understand how everything is interconnected and modifiable, and talk to them about their long-term risk and say, hey, here's the path we're on. You've had this challenges from a lifestyle standpoint or excess weight standpoint. You have this family history, and here's what we're starting to see, but here's what we can do. And like, here's what we can achieve, and then really dramatically change your long term kind of trajectory and natural history. I've seen people make dramatic lifestyle changes. And the good thing about young adults as well is that there's so much that's actually reversible in that early time frame that there's really a lot to be able to do. But in general, again, as Sadia said, sometimes you're going to be able to make a dramatic change from a lifestyle standpoint. Sometimes it'll be just in some things. Sometimes we need some pharmacotherapy in the context of having a really high long-term risk and maybe a family history or other risk enhancers, and then having still, so it's not one size fits all, but I do love the fact that we're giving more tools for people to be able to personalize those discussions with their individuals. That's why we're doctors. That's really what we're here to do, is to really kind of help support patients for their individual journeys to optimal prevention.
I love the point that you made about showing patients that they're on a pathway and kind of the direction they're headed in, but then you also provide those alternative pathways, or if you make those life changes, here's what you'd see later on down the road. And I think especially having both the short term and long term focus can be really helpful, because whatever's going on in a person's life at that time may preclude some changes, but maybe later on they may remember what was talked about and want to make those changes later on. But I like the idea of shifting the pathway. It's not once you're on it for good, but you can really kind of change the course.
And we don't know what the magic bullet for communication is. I mean, we may talk
Right.
more about that later. Well, I'll just say that Sadia has previously done some great work around kind of chronologic age versus, more of your vascular age. And,
Mhm.
and others have done that as well. It's a really interesting concept that sometimes really motivates people. Like, what? My vascular age is so far off. Like, I need to get back to making those, more comparable. So, it's hard to know exactly what is going to motivate folks, but I think, again, at least giving those tools is a really helpful starting point for really empowering that discussion.
Yeah, it's a really interesting perspective as you start to talk to more and more people, of finding out what resonates for them. And so, as Chatty mentioned, the prevent age or vascular age is one way to say, is my heart age based on my risk factor levels older or younger? And I think that's a lot easier sometimes to understand than saying that your 10-year risk is 5%. And that means if we saw 100 people like you, that 5 of them would have an event in the next 10 years. And sometimes that can be really hard to then internalize. Is that high? Is that low? Is there something that we should do about that? Whereas there's something more inherent about saying, if my heart is aging faster than my chronologic age or my date of birth, what can we do about this? And then it can also be empowering. And there's action items that can be taken to really lower that risk or lower that heart age.
And it goes back again to the kind of the theme, I think, of this entire conversation, which is personalization and laying out all the information for the patients and finding what particular item of what we're chatting about resonates the most with them, because it is very different for everybody. And so I think the more information we can provide people, the better. I know we talked a little bit about the role of community level data and really understanding neighborhood factors, the mention of the zip code. And I know, from training, when we move around, our patient population can be so different from the population we had in residency or med school or fellowship and then now as an attending. How do you find that these neighborhood factors and things that go beyond the traditional models that we've been using for this long, how does that really help us in personalizing not only their risk, but helping them in preventing, future events?
Yeah, it's a really important question. I would say that these broader social factors are really important to how we conceptualize prevention these days, certainly in the construct of cardiovascular, kidney, metabolic health. They impact what our actual health behaviors are, based on, our broad lived environment and our personal circumstances. They certainly impact when risk factors emerge, when they get identified, how they're cared for, and then all the complications that can result from them. So there are really multifactorial risk enhancer to consider as we're thinking about risk. And there's no question that, if you have, at least in the United States, it's a little bit different in actually globally, but in the United States, if you have a higher socioeconomic status, by definition, we generally kind of overpredict your risk based on your risk factors. And if you have a lower socioeconomic status, we generally are going to slightly underpredict your risk. So this also really underscores Sadia's very important point that, these risk assessments are a bit of a starting point as opposed to like the end point for understanding individuals' risk. And now we have the social deprivation index as part of the model, which I think is a really helpful and important advance that probably won't change your risk discrimination, the C statistic, very much. We certainly haven't seen that in the data, but does have the potential, particularly for the individual, to help refine the calibration a little bit, where it's basically more right sizing what we're seeing from a risk predicted to observed standpoint. So I think it's a really important piece. I will say that above and beyond just predicting and using that to refine prediction, I also think it's really important to understand how addressing the adverse social determinants of health wherever we can is a really important part of the care model holistically for individuals from a prevention standpoint. So just, you know, telling two different individuals from two different scenarios to say, hey, we need to engage in some healthy lifestyle change or adhere to medicine. If your lights are off and you can't get transportation, or you're worried about your neighborhood in terms of its safety, or you have food insecurity, all these things are very, very different for some individuals. So I think it's an important thing to conceptualize as part of our prevention care model, and it's certainly an important thing to conceptualize in terms of risk.
And I think your point about how we need to address this is so critical. And part of the goal in incorporating it into risk prediction was, yes, to help the calibration of the model based on the social context and really pull in what we had available in terms of the zip code level social deprivation index. But it's really to start the conversation to say, how do we address it? And that different people coming from different neighborhoods have very different circumstances, and that affects their health. It's not just a social factor, but it is intimately tied to their risk for cardiovascular disease, to their ability to access care, and as well as optimize their health. And how do we, as a health system, as a community, as clinicians, start to incorporate that into healthcare? And that healthcare is not just about prescribing blood pressure medication, but it's about understanding, do you have a place to go pick this up? Are you living in a pharmacy desert and you don't have access to be able to get your medication? And so I think, Jody, that was just such an important part of the work you led in the cardiovascular kidney metabolic framework. And on top of that, having a care coordinator that helps to really engage with the patient and helps to think about how we deliver not just the medical part of care, but incorporating the social part of care as medical care.
Yeah, absolutely. I have no notes. That was like, I have no comments. I'm learning a lot with just this conversation. And I feel like the point you made about when you're trying to educate a patient, you really have to take into context what's going on at their house. I mean, if they don't have lights, then what are we talking about? I think that's just really poignant and something that maybe we don't realize every day. And that's something we really have to take into context when we're talking to patients. So now I have a question just from like an implementation standpoint. And, as a fellow who wants to be using this prevent score in daily practice, how do you find, or what do you find are some current barriers to implementation and how do you recommend clinicians start to transition to using this in daily practice besides just using it, I suppose?
Yeah, I think lots of different implementation barriers that have been noted, and really hoping that we will be able to continue to work on addressing them. For risk prediction in general, we've known since the pooled cohort equations were published and recommended in the guideline, there are barriers related to actually calculating the score, using the score to deliver therapy, and then for adherence to those therapies. As Shadi mentioned earlier, things have gotten a lot more complicated. And so now with the Prevent score, I think one of the barriers is understanding that there are different outputs. We've been talking a lot about 10-year and 30-year, but we also have different outputs for total cardiovascular disease, which is the outcome that was included in the hypertension guideline. There's also the ASCVD or atherosclerotic cardiovascular disease outcome, which is what we're more familiar with for cholesterol treatment. And there's the heart failure outcome. So I think one of the first things in terms of barriers for implementation and that we're working on is really helping to inform people of the different outcome models, what they represent, and how they each should be used. So I think that will be really helpful. The second piece is having the rollout of the various guidelines that will incorporate the different models. And we have the hypertension guideline that's out. But as the primary prevention suite of guidelines from AHA and ACC come out with their multi-society collaborators for dyslipidemia, for CKM syndrome, for primary prevention, which are all expected in the next 12 to 15 months, I think we'll have a better sense of clarity as well of what thresholds mean, how we act on them, and what preventive therapies are recommended. And then the third thing, I think, while there are many more that I think are in my top three, is integration with electronic medical records. We have to make things easier for clinicians that are in a busy practice and going from patient to patient and be able to automate this and then also help to disseminate it.
And those were my top three as well. So I very much agree. The only thing that I would add is that there's a lot of patients or individuals in the community who want to better understand how to use Prevent, who are going to the website and checking it themselves. So making sure we're providing the education to help them better contextualize and understand their risk and empower them for being able to be active participants in the risk discussion with their clinicians that they see, I think is also really important. But I agree completely. The steps that are going to be necessary to help us make this, I think, important and necessary transition to these newer risk models.
It's such a great point, too. I think a lot of times when we think about implementation and potential nudges or other ways that we want to think about really helping to increase the uptake of guidelines, we often focus on clinicians and health systems, but really going directly to patients and increasing the amount of work that we're doing from a public health messaging standpoint is going to be really important, too.
I love that. We were segueing right into the next question, and your comment fits perfectly. I think, especially when I started residency to now, patients are really have more at their hands and their fingertips to really understand their health. And they're also seeing our notes, seeing documentation, and really trying to understand everything together. What are some recommendations or steps that you think clinicians can do to really better communicate risk scores to patients, recognizing that numbers don't tell the full story and there's other components that we've chatted about at length, even risk factors, social determinants of health? How do you really think that clinicians should start that conversation about their risk to their patients? Or if a patient comes to you and says, "Hey, I calculated my prevent score, but I'm trying to understand what that really means."
Yeah, I think Sadia made the great point that, we really, want to look at the risk score output as a starting point for the discussions that we want to have with patients. And they're never going to be perfect. That's just the nature of these scores. They're at the population level. They're not going to be perfect at the individual level, but they're a helpful starting point. So I think saying, okay, first of all, being able to put that into context. What does this mean? The score that I'm seeing in front of me, is this high? Is this intermediate? Is this low? That's a really helpful starting point. But then I think after that, there's other things that provide more context. So like, for example, if your score is, should you be very reassured, or are there other considerations that may impact how you should be thinking about risk? Do you have some risk enhancing factors? Do you have like an inflammatory condition, or you have a family history that might make you even more vigilant from that standpoint? Are there other aspects of your overall risk profile that, we should be optimizing to better improve your long-term health? What does your 30-year risk estimate look like? And is that, even if your short-term estimate is low, does your combination of what you have in your risk profile indicate that for your given age, your percentile of 30-year risk is quite high? Or, as we talked about, the chronologic age versus vascular age question. I think those are all really important considerations. And I think that help empowering clinicians to use these tools to engage in risk discussions and to better communicate risk, I think is going to be a really helpful and important part of what needs to come to personalize these risk discussions with patients. Sadia?
Yeah, I think those are great points. And one of the things that I think this really points out is that we need more research in what risk communication tools are effective. And there's not going to be a one size fits all. For some people, numbers are really helpful. For others, a visual abstract or a figure or chart is going to be more helpful. And I think understanding different levels of health literacy is also going to be critical in communicating this information. I do think while I'm generally skeptical of AI as being the absolute answer, I don't know that any podcast can actually be completed in 2025 without mentioning AI. It's like COVID, right? Like you couldn't talk about anything. You'd be talking about the weather and somebody would say, but it's going to rain because I just got a COVID exposure. But it's okay. It wasn't that funny. It's okay. But I do think one of the things that AI has been underutilized for is helping to translate to different health literacy levels the same information. And it is a really useful application when we often are not communicating information at the level of the person in front of us, whether that means that it is under their level of health literacy or over their level of health literacy. For some patients, they want more and more and more information, and they are looking to the internet for that information because we're trying to hit an average 8th grade reading level to try to capture more people for a lot of the information that we're putting together.
The one other really important consideration, as you mentioned, the visual, which could be the visual of the risk scores, there's also, or visualization of the risk scores, there's also sometimes understanding what's actually happening in your cardiovascular system is also can be very motivating for the right patients. And we know that measures of coronary atherosclerosis, like coronary calcification, if you're kind of in the middle with regards to your risk assessment intermediate level and are uncertain about which way to proceed, these can really either up risk you and tell you, wow, you actually should be a little bit more concerned, or they can actually de-risk you and say, it's reasonable to be a little bit less aggressive for right now from a short-term standpoint. So I think that's important for atherosclerotic cardiovascular disease. I also think that we're seeing increasingly, and Sadia and I just published something recently, data in this regard for subclinical or pre-heart failure as well, so that early heart changes are also a really important consideration. So I think, particularly in that intermediate risk group, there'll be some individuals for whom, yes, getting more clear communication about the risk scores will be helpful, but there may be some individuals who getting a picture of the early changes that are happening already within their cardiovascular system will be particularly motivating either for making lifestyle changes or getting on pharmacotherapy.
Yeah, it brings back the point of the holistic approach and really taking all the tools we have and integrating it to provide the best picture that we can for our patient. Just as an aside, we've kind of talked about ways to communicate with patients and patients turning to the internet. I'm curious your thoughts on the role social media really plays in kind of disseminating information to patients, both in an effort to kind of combat medical misinformation, but also as a way to really explain things to patients in maybe bite-sized format.
Yeah,
Sadia, since you're younger, do you want to start with that? Since you've made clear my age, I'm going to get in trouble for that one later. Go ahead.
it's okay. I think what the better way to frame that rather than from an ageist perspective is that I'm just better at social media and everything.
Okay, that works as well.
Yes, there we go. I think it's both exciting and overwhelming when we think about social media, right? It's very exciting to consider the opportunity to share from trusted information and deliver trusted content to patients when they're looking for answers and have questions about either their health, about their test results, and about what actions they can take. But it's also overwhelming when you think about the breadth of different platforms as well as different resources that someone can go to. So, how do we curate that? And how do we help our patients curate what are trusted sources of information and provide that for them? So, I think it's a great opportunity, but I think figuring out the best way to do it and the most efficient way to do it is really the challenge.
Yeah, and I think that it's super important focus area. And we need to do a better job of meeting people where they are and where they get their information. I suspect that, it will take even more engagement of our emerging leaders who have, who are in that space and have even more familiarity to really kind of make sure that we're getting the right information to individuals in that realm. There is a lot of misinformation there, and I think we want to really help people know that there's some trusted sources that they can say, hey, this is how I can really understand my risk a little bit more reliably.
On the same token of what we were talking about, social media and things like that, in a well, I guess it's not on the same transition point. What's one thing you'd love to see in how we really teach cardiovascular prevention to trainees? What is something that you think would be implemented to really help any point of training? We've talked about med school level, we've talked about high school, we've talked about college, fellowship, et cetera. How do you really think that we can change how we teach prevention to trainees?
Prevention as part of cardiovascular training has always been embedded in general cardiology fellowship training. And I think as we are seeing the complexity of preventive cardiology really expand, one of the things that I think we really need is more focus and emphasis on how we approach prevention, whether that's from the perspective of assessment for cardiovascular kidney metabolic syndrome, whether that's from the communication perspective of risk, or from a treatment perspective. And I think there are some considerations around, does that really mean a dedicated fellowship year, or is it really better embedded within the general fellowship? But I think the expansion of that is something that we have to take a moment and recognize that preventive cardiology has come a really, really long way. Not just that it's an exciting time, but that there's a lot more to do and learn. So having a framework for how we want to approach that is going to be really helpful.
Yeah, I agree completely with that. And I think that, in the modern era, there's a few things that are going to be really necessary. So it's probably helpful to take a step back and realize that we've had a significant shift from a population health standpoint over the last decade and a half. Well, actually several decades, but we're seeing the results of this over the last decade and a half, where previously we had kind of continuous declines in cardiovascular mortality. And now that's actually plateaued and actually started to uptick in the last couple of years. So we are not making the progress and actually going in the wrong direction relative to where we were. So to Sadia's point, thinking about the factors that are driving that are largely related to cardiovascular kidney metabolic health is important. But then I think it's also important that we often engage with people when it's like, okay, you're now in my preventive clinic because you have high blood pressure or dyslipidemia or diabetes and or chronic kidney disease is not really why they're coming to me now, but it may be in the future. But these are they don't come out of nowhere. They are risk for this, and the nidus for this accumulates over the course of several years beforehand, where it's that excess adiposity, insulin resistance, those early changes, and then one day they have a more overt risk factor profile. So that's really the purpose of thinking about the CCAM staging. It's not to add another you know, construct that people have to start documenting, but it's more to kind of be able to help patients understand that this risk doesn't come out of nowhere and that we can predict this, we can also prevent this, and we can kind of be thinking about this earlier. I think that's really important. I think it's also going to be important for us to move beyond our silos. So not just thinking about the cardiovascular system, but we have to think about endocrine, we have to think about kidney, and we have to think about all of it because the things that we're going to be increasingly prescribing have multi-system effects. So everybody needs to be thinking about this more holistically. And then I will also say that I'd love for us to be thinking more about the social context as well and thinking about, hey, the patient in front of me, I need to understand their social needs as well as their clinical profile and use that to refine how we're thinking about prevention for that individual.
One other thing that, as you were talking, Chatty, that I just thought of is that we often think about preventive cardiology as preventive cardiologists, right? Like as our specialty, but there's also the importance, and I think the kind of question around how do we talk to trainees about this is that preventive cardiology now spans every single subspecialty of cardiology. If you have a fib and you're seeing an electrophysiologist, we want our electrophysiologists to be trained in preventive cardiology as well, because it's going to be so critical to think about the secondary prevention aspects, like for managing weight. And if that is a critical reason why there's recurrent AFib, for interventional cardiology, as we think about for post-MI care and what are the therapies that are now available and effective. So I think part of also the scope of preventive cardiology from a training perspective is really understanding that secondary prevention is still critically tied to the factors that we think about in primary prevention as well.
Yeah, I think that's a really, really important point. It's so often the case. It actually just happened a couple weeks ago where you have somebody who has very substantial early valvular disease, for example, and then, they've come in and they've had to have an early valve procedure, and they say, "Hey, has anybody checked in lipoprotein A?" And then the proceduralists don't even know that there's a link between LPLA, and then you say, "Hell, you get an LPLA that's like 300, which is what happened recently," and then they're like, "This is what's driving that." So I think having a greater appreciation and understanding that we need to be thinking holistically about these preventive factors, not just for primary prevention, but for secondary prevention is, I think, a really, really important point. So we want to really help people have healthier lives across the full spectrum of risk and disease.
Well, what an amazing conversation this was. I mean, I love that we started with patients, we ended with patients. Lots of discussion about taking a holistic approach to patients' risk and recognizing that there's a lot of factors, things that we don't think about every day. I know I learned a lot from chatting with both of you, and I really appreciate y'all taking the time and really excited to see what comes in this space and to learn more from you both.
Thanks. It's always fun to talk with Chiadi, and we're excited to be able to share this with the ASPC community.
Yeah, it's really a privilege. Thank you very much. It was a great conversation.
Thank you so much for listening. To learn more about the ASPC, please visit our website at aspconline.org.